Welcome everyone to episode 33 as we do a deep dive on the question related to the topic effect of obesity on pharmacokinetics. Now, this was a question submitted by one of my patrons, so thank you very much for submitting this really challenging question in. Now, a lot of you are new to this channel, and I want to just quickly give a quick summary of what I'm all about. So I want to create a framework that stimulates your thought processes and releases adrenaline to facilitate attention to detail and assist your brain in creating long-term memory. Because after all, this is how we learn. We get excited, and this is how we create our memories. Now, why Patreon? So Patreon helps keep me motivated to provide a product that is of value to you. What is my motivation? It's a positive growth mindset. I want to help you excel in the ANZCA primary exam, and all the money raised supports activities that are committed to positive growth. So these include, but are not limited to, the ANZCA Research Foundation, as well as other charitable organizations. And I encourage you to join my Instagram page where you can actually see where all these funds are going to each month. Now, as always, the breakdown of the SAQ. How do I do this? So first of all, I'm going to review the examiner's report. And then after that, I will show you the literature that I use to basically give a broad overview of the key concepts that are there. And then after that, I'll go through any questions that you might have, and I'll show you an answer structure, and we will both, or rather all of us, will write an answer to time. Now, this is the question. So it's from 2009, B, question 4. And the question is, describe the effect of obesity on pharmacokinetics and the potential clinical implications, providing relevant examples. Now, with the examiner's report, what I've done is anything that I think is needed to be included in the answer, I've highlighted in green. Anything that's neutral, I've just left it as black. And anything that's negative or should be left off, I've highlighted as red. So let's go through this examiner's report. This was a question with which most candidates struggled, possibly because it required bringing together information from a variety of areas. Most candidates started off appropriately with a definition of obesity, and then went on to point out that it was often associated with a range of other comorbidities, such as diabetes and gastric reflux. Now, just a point of note here, there have been other SAQs in the past when they've talked about a certain condition, a physiological condition like obesity or, let's say, aging, they didn't want you to talk about any other comorbidities associated with it, and solely focused on the physiological condition. So for this answer here, I'm really just going to focus on obesity, despite the examiner's report sort of hinting that the comorbidities such as diabetes and gastric reflux could be included. But I think there's enough in this answer to not have to worry about these concepts. So let's go on. Then, possibly relying on clinical experience, candidates often remarked that in the obese patient, FRC can be reduced, thus affecting uptake of volatile anesthetic agents, and that transdermal, intramuscular, and subcutaneous drug absorption was also likely to be affected. Many candidates also mentioned that some computer-based programs for TCI could give variable results when actual rather than lean body weight was entered. However, there were few instances where specific examples were given as asked for in the question. Pharmacokinetic handling of some opioids are altered in the obese patient, and only few candidates mentioned the possible pharmacokinetic advantages of poorly lipid-soluble volatile agents, such as desflurane over other volatile agents in the obese patient. With regard to non-depolarising muscle relaxant drugs, although their polarity generally restricts their distribution, volume of distribution may be increased in the obese simply by virtue of increased absolute total body water. There will be differences in the distribution and hence duration of action depending on whether dosage is calculated on the basis of ideal body weight or total body water. From a clinical context, obese patients are comprising an increasing proportion of our population, and candidates should be aware of how this condition influences drug disposition. Wow, that's a lot to unpack there. And as you can see from the examiner's report, there really isn't a clear structure other than sort of going through drugs which they think is important to be included in this answer here. So the way that I've summarized the examiner's report, or rather what the key points are that I think you need to include in your answer, is that you need to have a definition of obesity, and certainly not too long. I'd probably leave it at one line. You also want to discuss the uptake of volatiles, specifically ventilation divided by the FRC or the ventilation FRC ratio, and also a comparison of DES versus SIVA, or a quick comment about that. And then also we want to talk about absorption, specifically transdermal, intramuscular, and subcutaneous. Propofol, specifically the TCI models, and lean body mass versus total body weight. Opioids, and they give a very general comment about pharmacokinetic handling. Nothing sort of specific on that, rather a very open interpretation of what that can mean. And finally, we also want to include non-depolarising muscle relaxant, specifically the volume of distribution and the idea of ideal body weight versus total body weight. Now, with what I'm going to present in this presentation here, I'm going to present a lot of what we think could possibly happen in terms of what the applied concepts are, but really also what the evidence shows as well. And I know there's a lot of model answers that talk about very conceptual applications of some ideas, but I'm actually going to show you what the evidence shows as well, okay? And you'll see that there's actually quite a bit of difference between the two in some cases. Now, this is the literature that I've used. So for most of these answers here, I will try to restrict myself to the core or prescribed textbooks that ANZCA has recommended. And in this answer, I've gone to chapter 18 and chapter 27 in Miller's Anaesthesia, and I've put those in the post in the latest Patreon page regarding this. Now, this wasn't enough to actually complete the answer. So I've had to go outside and look at some other articles. So I've also included an article from Blow-In, Pharmacokinetic Considerations in Obesity, one by Hanley, Effect of Obesity on the Pharmacokinetics of Drugs in Humans. There's a website link here. And also another article, a BJA article by Ingrande, Dose Adjustment of Anesthetics in the Morbidly Obese. Now, this is how the evidence is often presented in textbooks. So in Miller's and even in the examiner's report as well, they really talk about the effect of obesity on specific drug classes. And I think the main ones that you want to be talking about are volatile agents, propofol, opioids, muscle relaxants, and others such as anticoagulants and antibiotics. However, the common structure, or rather, I think what a lot of us will sort of think of when we think about pharmacokinetic, especially the idea of pharmacokinetic handling as per the exam's report, is we think about absorption, distribution, metabolism, and elimination. Now, what I'm trying to do more often now with these answers is sort of present to you sort of two types of structures that you can use. And normally I try to present sort of the more how would I say, uncommon one. Now, the reason why I'm going to do it this time with absorption, distribution, metabolism, and elimination is that I think it's actually a lot more difficult answering this question using this method. It's literally like trying to fit a square peg into a round hole, and I'll show you why. And the reason for this is because of how a lot of drugs, okay, are affected not just by one component, but by another component as well. So I'll show you how in sort of the upcoming slides. Before we go on, it is important to understand about weight scalars and the different types that are out there. I know that the most common is going to be total body weight, and you do want to know about ideal body weight, lean body mass, and those will probably be the three main ones. Now, if you want, you can also think about fat-free mass and pharmacokinetic mass as well. They're very specific for certain drugs. So fat-free mass would be specific for Remifentanil, and pharmacokinetic mass will be very specific for fentanyl. I've just summarized the equations here. I think that if you can, do try to remember the formula for ideal body weight. I've just converted the numbers into a metric scale. The one before had it in feet and inches. And I've also given you the formula for lean body mass, a little bit more complicated. Look, I don't think you have to remember this, but if you can, fantastic, please do. This is lean body mass, which is the James's formula. This graph here is really interesting. So the black line here represents total body weight. And you can see how using each formula, the weight changes. What is most interesting is the idea of lean body mass. So this is this purple line here. And from that previous formula, which you saw, it is a quadratic function. So that after a certain limit or after you reach a certain BMI, it actually starts decreasing. This is really important because it has implications with how dosing occurs in the Schneider model. And I'll show you how Schneider protects against this drop in BMI, in lean body mass calculation. Now, ideal body weight is a straight line because that's always just corrected for height. And then after that, you've got other ones such as free fat mass, which is the green. And I think this is the corrected body weight, which is the indigo line here. With the summary of Miller's chapter 18. So we're going to start with Propofol first. And what I've done is every time I see a key term being used when I'm talking about the specific drug, so such as absorption, distribution, metabolism or clearance, as well as elimination or excretion, I'm going to bold it and highlight it just to act as a marker of where I need to put it in into those sort of subheadings at the end. So let's start off with Propofol first. So with Propofol, distribution should influence your bolus dosing. What is really interesting is that with obesity and the increase in total body weight, that increase in total body weight is not just from fat. So fat is about 2/3, and non-adipose tissue, so that would include muscle and organ mass, represents 1/3 of that increase. What is really interesting is that that organ and increase in muscle mass is a highly vascularized compartment, whereas the fat-free mass, the fat mass is a poorly vascularized compartment. And when you think about that in terms of kinetics, it is the highly vascularized compartment, which is going to play a major role in your bolus dosing. And so knowing this is why you don't use total body weight when you do bolus dosing calculations for Propofol. In actual fact, what has been shown is that lean body mass is a lot more appropriate. However, when you think about clearance, so clearance influences infusion dosing. And if we think about pharmacokinetics and we think about what the maintenance rate infusion is, your maintenance rate infusion equals for a one compartment model, equals your target concentration multiplied by your clearance. And so what it's been shown with Propofol and increase in body weight, or rather in obesity, in obese patients, is that they have increased hepatic blood flow due to two things, from an increase in liver volume, as well as an increase in cardiac output. And because they've got an increase in hepatic blood flow, that increases the clearance of Propofol. And so what Miller's is suggesting is that when you think about infusion dosing, total body weight is more appropriate. And that's quite interesting to actually point out. It's not because of the tissues, or rather the increase in fat tissues, which is a poorly vascularized area that you should be using total body weight, but it's rather the association of what happens in the liver. So that's really interesting. Now, I want to quickly go through the TCI models of propofol. So we've got the MARSH, and the inputs for MARSH are age and weight with a weight limit of 150 kilos. And I've just taken a snapshot here where you can just play around with it in the infusion pumps, with the infusion pumps in your theater. So these are the inputs. And as you can see, they've limited the weight from a minimum of 30 and a maximum of 150 kilos. And the reason they do that is to prevent overdosing. When we look at the Schneider model, which has the inputs of age, sex, height, and weight, they need this because they need to calculate lean body mass, or rather specifically, sex, height, and weight is used to calculate lean body mass. Age is needed to calculate the rate constants from compartment 1 to compartment 2. So K1, K12, and K21. Okay. Now, remember what I said in the previous slide is that when you calculate lean body mass, it's a quadratic function. And what happens is that it starts dropping off after a certain BMI. So Schneider's models actually protect against this by having a BMI limit of approximately 42 for males and approximately 35 for females. And I've just added a snapshot here. So we have a 40-year-old male who's 180 centimeters, and you can see that the maximum weight that you can put in is 139 kilos. And if you do the calculations, I think it gives you a BMI score of 42.9, okay? And similarly with this one here, this is for a female who's age 40, 180 centimeters, and the maximum weight that you can put in is 117. And the BMI, if you calculate this one, is probably 35.9 or around 36, okay? But they've got set BMI limits, and this helps prevent underdosing, because once you go above those BMI limits, your lean body mass actually starts decreasing. The other interesting thing that I want to show you is that when you look at the Marsh and Schneider model, so quite often the Marsh model, you tend to use plasma target concentrations, whereas for the Schneider model, you tend to use effect site target concentration. And for the same sort of parameters, you can see that the bolus dosing is approximately the same for both. So I've got Marsh, age 40, 150 kilos. If you want to get a target plasma of 3 mics per mil, you need 12.4 mils. And in the Schneider model, someone who's age 40, 187 centimeters with a weight of 150. If you want to get a effect site target of 3, you have to bolus them 12.8 mils. And not much, is it? So that can often give you a clue that 3 mics per mil is probably not enough for an induction dose for these patients here. But I encourage you to, go into theater and have a look at these models and play around with it and see what is the dose, or what is the bolus dose that these models will calculate for you. We move on to opioids now. And I know that the examiner's report stated that there was a great effect in terms of the pharmacokinetic handling of opioids. Now, I've copy and pasted a section from Miller's, which states, with the exception of remifentanil, minimal work has explored the implication of obesity on the kinetic and dynamic behavior of opioids. This line here, stunned me, because as I said, a lot of times we put in concepts that we think should occur, but there's actually not much evidence for that. So let's see what evidence is there for opioids, specifically for remifentanil. Now, with remifentanil and its metabolism, there is increased activity of non-specific esterases. So much so that the distribution and clearance is very similar to lean patients. And what it shows is that fat-free mass is the most accurate for calculation of remifentanil. Now, this is a really interesting graph. And what we have here is that if you look at the blue line here, which is the total body weight for lean patients, so this would be your standard patient, okay? So using total body weight for lean, this is the time versus the remifentanil effect site concentration. And what you want to do with dosing for someone who's obese, you want this to be as close as possible to the total body weight of lean without overshooting. And from here, you can see it's the green and the yellow that are closest. And the green and the yellow are fat-free mass and ideal body weight. Whereas you look at the ones that have overshot, if you use corrected body weight, you will overshoot. And if you use total body weight for the obese patient, you will also overshoot as well. However, if you start using lean body mass, so remember in Propofol, we were using lean body mass, it actually undershoots significantly. And so therefore, the one that is recommended is fat-free mass. And this is another graph that sort of shows the same concept. What they have here is time versus probability of analgesia. And you can see that the ones that are closest to the total body weight in lean patients is again going to be that using the calculations of fat-free mass and ideal body weight. Whereas the one that clearly undershoots is lean body mass. So just to summarize, in Propofol, we're going to use lean body mass, but in remifentanil, we're going to use fat-free mass. And if you can't remember, you can always say you can use ideal body weight, because as you can see, it's sort of fairly sort of similar here. But I will give you a word of warning, is that I think that if you do use ideal body weight, it does actually change the calculations when let's say these parameters change a lot more significantly. Okay, so in this example here, it so happens that fat-free mass and ideal body weight are actually very close together. Distribution. So distribution with inhalational anesthetics. There is a perception, okay, that for obese patients, there is going to be prolonged emergence due to accumulation in fat. This is completely lacking any evidence at all. In fact, the research has shown that there's no significant difference between SIBO and DES when titrating to BIS. And the reason for this is, as I said before, when you think about the increase in mass, which is 2/3 fat, fat is a very kinetically slow compartment. And so that it actually has a very long time constant. And when you look at DES, the time constant of fat with DES is 1,350 minutes. So that's approximately 21 hours. And with ISO, it is 2,110 minutes. So extremely long. And so, if you're not running your volatile anesthetics for, hours on end, it's not going to make a big difference at all. And remember, when I'm talking about time constants here, so time constant is the time it takes for completion to 63% of what the end result would be. With the washing of volatiles, again, there's no evidence. And I think that when we think about it conceptually, we want to naturally state that the increase in your ventilation to FRC ratio will increase washing. So with obesity, you will have a reduction in FRC because of the mass over the chest wall, and it will decrease your FRC. And then also there is an increase in ventilation as well. However, the opposite of that is that with an increase in cardiac output due to that increase in your lean body mass, that will actually decrease your washing. So I believe the net effect is that, you may have an initial increase in the rate of rise of your FA-FI curve, but otherwise, after a couple of minutes, I don't think there's any significant difference when you compare it to the non-obese patient. what should be obvious, and I think it's even obvious in non-obese patients, is that as you decrease the blood gas solubility of volatile agents, you are going to increase the wash-in, okay? And that's even for, as I said, non-obese patients. And in order, this will be DES faster than SIVO, faster than ISO. And that, normally I probably wouldn't put this in, but because it is an exams report and probably won't take too long, I will include this concept into my answer. Moving on to neuromuscular blockers. For succinylcholine, we are going to use total body weight dosing. And you might ask, why are we using total body weight dosing for succinylcholine at 1 milligram per kilo? And very similar to remifentanil, where we are not using, we're not sort of using the ideal or lean body mass. The reason for this is that there is an increase in activity of pseudocholinesterase. So there's an increase in the metabolism, which then means that instead of using theoretically lean body mass, which is probably where, succinylcholine, which is a very polar drug, is going to distribute to, you probably want to use something higher. And in fact, it's going to be higher than fat-free mass, which is what remifentanil sort of suggests. And in fact, the studies that have shown total body mass is probably more appropriate. And remember that the other also key factor is that there is an increase in your extracellular fluid volume because of that increase in extra tissues. But primarily, again, the increase in ECF is going to be contained within sort of your lean body mass area. Now, with the other non-depolarizing muscle relaxants, you will see this described in Miller's. So it says there is no difference in the PK variables. Now, I had to go and look at the actual paper where they've quoted this. And what they meant is that there's no difference in the pharmacokinetic variables in absolute terms. So they compared obese patients and non-obese patients. And when they looked at the distribution in terms of liters and clearance in terms of liters per minute, there was no difference in absolute terms. But when you corrected it for per kilo basis, so the volume of distribution now became liters per kilo, and the clearance became liters per minute per kilo, or liters per hour per kilo, what you saw was that the volume of distribution and clearance actually decreased. And the reason for this is that despite there being an increase in your total body weight, lean body mass, and extracellular fluid, not all the increases are proportional. In other words, have a look at this diagram here. You've got an increase in your total body weight. You've got an increase in your fat weight, which is fairly sort of proportional to how it rises with total body weight. But then you've got lean body weight, which comes up and then sort of plateaus once you've sort of reached a BMI of 40. So that's really, really interesting. And therefore, when we think about non-depolarizing muscle relaxants, despite there being an increase in extracellular volume or extracellular fluid, when you think about it in terms of the ratio between ECF and total body weight, there is actually a reduction. And therefore, using total body weight for non-depolarizing muscle relaxants has been shown to result in a prolonged duration of action. And therefore, ideal body weight there is more appropriate. Now, I'm just going to summarize it again. So with Propofol, we are going to use lean body mass for bolus dosing. With regards to opioids and remifentanil, we're going to use fat-free mass. With succinylcholine, we're going to use total body weight. And with non-depolarizing muscle relaxants, we are going to be using ideal body weight. I want to move on to the idea of drug absorption, or rather oral absorption, because I know that there are a lot of model answers out there which talk about delayed gastric emptying, decreasing the peak of any sort of drugs that are taken orally, or conversely, that there also might be an increase in gastric time as well. So this is a paragraph from one of the journal articles, or rather from Bluen, which states that the effect of obesity on absorption and overall bioavailability is poorly understood. In contrast to expected decreases in bioavailability associated with increased splanchnic blood flow in obesity, the bioavailability of midazolam and propranolol, two compounds with moderate to high hepatic extraction, was shown not to be significantly different between obese and lean individuals. And overall, studies indicate no significant difference in absorption between obese and lean subjects. And there's also another journal article which says oral drug absorption does not appear to be altered in obese individuals. So this is really important. I think that when we think about the different types of absorptions that may occur or that people think about, it often comes with other comorbidities. And the most common one is going to be diabetes, which is where you could probably lean that concept in of a delayed gastric emptying. But I think that if you think about obesity itself as a sole pathophysiological process, what's been shown with the evidence is that there's actually no difference between the oral absorption of drugs between obese and non-obese patients. With enoxaparin, so the other idea with absorption is what happens when you give subcut drugs. Well, this one here, there's actually good evidence for this, so that we know that with the increase in subcutaneous fat, there is a slower rate of absorption, and there is actually a delayed peak of subcut clexane. The other interesting thing is that clearance of clexane is proportional to body size, and it's a hydrophilic anticoagulant. And so therefore, the dose should be based on lean body mass. I know this is confusing, and just to sort of rehash it again, when we talk about non-depolarising muscle relaxants, which is also a hydrophilic drug, non-depolarising muscle relaxants, they want to use ideal body weight. Whereas with clexane here, which is another hydrophilic drug, we are talking about lean body mass. I think the key thing to sort of get out of this is that total body weight is rarely an appropriate weight scaler to use for a lot of the drugs out there. And if we are to use total body weight, such as in the case of Propofol infusions or with succinylcholine, it's in the setting, not because of the distribution, but actually because of the increase in metabolism or clearance of the drug, which is why we use the total body weight. All right, so we're going to delve into more ideas that are out there in terms of things that are hypothesized and what the evidence actually shows. And I think hopefully we can debunk some of those hypotheses out there, but there will be some that are actually true given the evidence. So let's see what we get from here. With intramuscular, again, the hypothesis is that the increase in subcutaneous tissue increases the difficulty of IM injections. And the implications are delay onset, because what it's suggesting is that if you try to give an IM injection, it's not IM, it's actually subcut because of all that fatty tissue. But what does the evidence say? The evidence is that it's only true for the dorsal gluteal and ventral gluteal regions. So any sort of IM injections in the buttocks in obese patients, this concept is true. Otherwise, for most other IM injections, which are given in the deltoid, such as vaccines, they haven't shown any significant difference with intramuscular delivery of drugs. With protein binding, again, one of the hypotheses is that there is increase in alpha-1 acid glycoprotein levels. And this increases the protein binding of basic drugs. And when you increase protein binding, there is less free drug available to distribute. And what that means is that it decreases your apparent volume of distribution. Okay. And so that what has actually been shown is that obesity does not appear to have an impact on drug binding to albumin. However, data regarding alpha-1 acid glycoprotein binding have been contradictory. So this is a little bit of a gray one here. So I think what that means is that you'll see some papers which actually show that this is true. And then after that, you'll see some other papers which show that it's not true. So look, in these cases here, I would probably leave this sort of concept out. This is a really interesting concept, which actually there is good evidence for this. So the other hypothesis is that there is an increase in phase 1 and phase 2 conjugation pathways. Phase 1, specifically the CYP2E1 isoenzyme, and that is implicated in metabolism of volatile agents. But really the most important one here is paracetamol. And what that means is that when you increase the phase 1 and phase 2 conjugation pathways, it's going to lead to lower paracetamol concentrations. But why don't we dose adjust for weight? Well, the problem is you've also increased CYP2E1, which is implicated in NAPQI, which is hepatotoxic. And therefore, because of this upregulation of the phase 1 isoenzyme, this actually limits any sort of dose adjustments that you think is appropriate based on weight. In other words, for paracetamol, we don't dose adjust. How about for the kidneys? Now, when we think about kidneys and elimination or excretion, this is going to be influenced by your GFR, by your tubular secretion, and your tubular reabsorption. With regards to GFR, there's conflicting evidence. So you'll see some papers which say that GFR has increased, other papers which say GFR has decreased, and others which say that there's no change in GFR. And again, possibly due to either the extent or the differences in obesity, as well as presence of other comorbidities as well. But what has been shown, and I think I'm going to include this because this is really interesting, is that there certainly is an increase in tubular secretion relative to GFR. And so for drugs that are secreted, you are going to have an increase in clearance of those drugs. And the specific one here, or the example here, is ciprofloxacin. And the other interesting thing is that there is a reduction in tubular reabsorption for a given GFR. So for drugs which do get reabsorbed in the tubules, if you decrease those reabsorption, you are going to increase clearance of those drugs. And the example here is lithium. So if you can remember this will be really good to put in your answer. Now I'm going to show you the structure of how I will go about answering this question with the ADME format. And what I'll have in my answer is I'll have a definition of obesity, and I'll talk about how it is 1/3 increase in organ and muscle mass, which represents the highly vascularized compartment. And then 2/3 will be fat, which is a poorly vascularized compartment. And my definition of obesity would be a BMI more than 30, and morbid obesity is a BMI more than 35. With absorption, I'm going to include subcut clexane, and I'm going to include the washing of volatile agents. With distribution, I'm going to include propofol and non-depolarising muscle relaxants. With metabolism, I'm going to be talking about succinylcholine, remifentanil, and paracetamol. And elimination, as I said, I'm going to be talking about ciprofloxacin and how there is an increase in tubular secretion, and lithium, where there is a decrease in tubular reabsorption. Now, if I've got time, so just depending on how I go with writing the answer, I will also include the idea of sort of the washout of volatiles and how there isn't actually any significant difference between obese patients versus non-obese patients as well. I think that will be quite an interesting thing to talk about. But yeah, we'll see how time goes. So grab your pens ready and let's get writing. Now, I've got my pen here and highly recommend the Jetstream pen, which has a very low resistance and will certainly help you with your writing speed. And I've got my little 15-centimeter ruler. Let's get started. I've got my stopwatch here and everyone ready, and let's go. Start off with my definition, and then after that, halfway down the page, we'll have absorption, distribution, and the metabolism down here. And then the last page will be elimination. Now, with my definition, so obesity equals BMI equal to 30 excess body weight is from 1/3 increase in muscle and organ mass, and that's highly vascularized, and 2/3 increase in fat, which is poorly vascularized. Now with absorption, so poorly vascular supply of fat impacts subcutaneous delivery of drugs, delays onset with subcut Enoxaparin, and with the uptake of volatiles. So the decrease in FRC leads to an increase in minute ventilation to FRC ratio. This increases the initial rate of rise of the FI curve. However, the increase in cardiac output neutralizes this effect. And then, so net effect is likely no change. And then after that, decreasing blood gas solubility of volatile agents leads to an increase in the FI curve. Des more than SIVO, more than ISO. With distribution, so increase in BD due to increase in organ muscle mass. Fat, not important. It is kinetically slow. Lean body mass before and Propofol TCI models use total body weight Schneider calculates lean body mass, but has limits due to quadratic function and potential for underdosing. So males approximately 42 and females approximately 35. Marsh has total body weight limit of 150 kilograms to limit overdosing and extracellular fluid increases, but not to the same proportion as total body weight. Therefore, ideal body weight more appropriate for non-depolarising muscle relaxants. With metabolism, there is an increase in pseudoesterase activity. Therefore, use total body weight for succinylcholine to achieve integrating conditions, increasing in non-specific esterase activity. So basically the increase in lean body mass, therefore fat-free mass. Fentanyl, and increase in phase 1, specifically CYP2E1, and phase 2 conjugation pathways, decreases paracetamol concentrations, but adjustments to dose limited due to increase CYP2E1, which produces NACQI, which is hepatotoxic. And finally, elimination. So there's increase in tubular secretion to GFR that leads to increase to ciproofloxacin clearance. There is a decrease in tubular reabsorption to GFR, and that increases lithium clearance. And I've got time, yes, 8 minutes 30. So volatile washout dependent on accumulation of volatile in tissue. However, that is clinically slow, high constant with days was 1,350 minutes with console equals 2,110 minutes. Therefore, no significant difference between 0 and there's washout and titrating to this. Oh, that's me. All right, that's time. It's 9 minutes and 40. And that's 10 minutes. How did you guys go? This is my answer here. And a copy of this will be posted onto my Patreon page. And I hope to see you all there.